Welcome to part 3 of the videocast for Block 1 Airway Equipment Types of ETT Airway Devices. My name is Dr. J. Thomas Murphy and I am on faculty at the University of Kentucky. I hope that you find useful information in the upcoming slides on this videocast. When a small bore endotracheal tube is required for an adult, quite often the microlaryngeal tube is the answer. As you can tell from this photograph, the external and likely internal diameters of these two tubes are approximately the same, but the size of the cuff and the length of the tube are different. For what it's worth, here is the title page of a 2014 review on endotracheal tubes, largely authored by respiratory technologists. As part of the article, there is an interesting discussion and subglottic drainage is discussed. This is a photograph of a cuff pressure gauge. When I first arrived at the University of Kentucky in 2002, I was quite surprised that there were no cuff pressure gauges in the department. And in fact, as far as I know, there are still no cuff pressure gauges in the department. Respiratory technologists often carry a cuff pressure gauge in order to verify that the cuff is not overinflated. There may be other devices that are available on the market that accomplish similar goals and increase the safety of cuffed tubes in patients. If the cuff pressure exceeds mucosal pressure or capillary pressure for an extended period of time, the mucosa sloughs, or the mucosa becomes ischemic, or ultimately a stricture forms. This is an avoidable complication, and in your ultimate practice, I would recommend that you learn methods whereby you can control the pressure in the endotracheal cuff for the highest standard of practice. There may be a quiz question on endotracheal cuff pressure. Now, let's look at a range of airway management products from Covidien. I'm not going to go into detail about each and every one of these tubes, but as you can see, there are single lumen tubes that come with stylets, oral tubes with special cuffs, nasal tubes with special cuffs, oral evacuation tubes to drain secretions away from the glottis, and so on. Continuing with the product line from Covidien, you can see that there are standard oral nasal endotracheal tubes cuffed with a Murphy eye, or with a shorter cuff, or with a low profile cuff, for example. Continuing with the Covidien line of airway management products, you see that there are cuffless endotracheal tubes, the already described reinforced endotracheal tube, a laser tube, a tube with a controllable tip which is called Endotracheal, and which may or may not be still ordered by the University of Kentucky. And a novel tube which I've never seen and which is described for use in the emergency department, one that allows you to either monitor gases or inject drugs, and that's on the far right with a monitoring lumen. It interestingly appears not to have a cuff. Moving left to right on this slide, you see the microlaryngeal endotracheal tube, the high-low endotracheal tube with a lance system where a valve automatically maintains cuff pressure at approximately 30 centimeters of water. The oral nasal EMT endotracheal tube designed for delivering medications during emergency situations. An endobronchial tube, which is a double lumen tube, and an endobronchial tube that comes with a CPAP system. Finally, this slide shows Covidien airway management products, which probably fall more into the adjunct or supraglottic range, with an esophageal endotracheal double lumen airway, and which is a device that I've actually never seen. A common nasopharyngeal airway, the intubation stylette, which, as you can tell from this slide, comes in 3 sizes and begs the question, why do we only have 1 or 2 sizes at the University of Kentucky? And finally, a Shiley endotracheal tube holder. Now, going forward, we're going to review tracheal tube guides, introducers, and stylets. In the 3rd edition of Benjamoff and Hagberg's Airway Management Textbook, there is a chapter titled Intubating Introducers, Stylets, and Lighted Stylets, brackets light wands. This photograph shows a stylet shaped and positioned in an endotracheal tube and meeting the description of straight to cuff. In other words, the stylet is relatively straight to the cuff, at which point the endotracheal tube can be bent to the desired angle, and in this photograph is described as a hockey stick. In other resources, the angle of 35 degrees is often quoted. In this photograph, also extracted from the 3rd edition, you can see at the top of the slide an endotracheal tube. The next item is the Eschmann introducer, and in the literature is often referred to as the gum elastic bougie, with a J or coude tip. The item labeled B is a Frova intubation introducer. We have those in stock at the University of Kentucky, and they are produced by Cook Medical. This introducer comes with an optional rigid internal cannula, and there is a ventilation port which can be used to deliver oxygen. Item C is a single-use endotracheal tube introducer by SunMed, which I think you'll find on the back of your Bluebell. And item D is a Cook airway exchange catheter. You will find these here at the University of Kentucky and are designed for exchanging one tube over another, typically with a laryngoscope blade in place in order to ensure that there's not buckling or maladvancement of the endotracheal tube over the introducer. This technique is often called railroading. In doing my research for this video cast, I came across this entry in Up to Date, which appears to have been written by our colleagues in the field of emergency medicine. Being up to date, you can see that it was last updated May 9th, 2019. I do have to say that what is shown in this slide is not anything that I didn't know many years ago when the Eschmann introducer, or the gum elastic Bougie, was one of the very few airway adjuncts that we had. As has been known for a long time, the use of the Eschmann or the gum elastic Bougie or similar devices does provide a tactile sense when the device clicks along the tracheal rings, helping you to confirm that the device is in the trachea. The authors do caution that it should be used very carefully if there is possible laryngeal or tracheal injury. The technique described on this slide does not reinforce or make clear that this is something that is done with a laryngoscope in place, at least when one decides to advance the endotracheal tube over the Bougie or introducer, in other words, what is called railroading. This slide is excerpted from Up to Date and is reproduced with the permission of Dr. Adam Law. Dr. Law is on faculty at Dalhousie Medical School, which is my alma mater, and he is also a member of the faculty of the Difficult Airway course, which was founded by Dr. Michael Murphy, a classmate of mine. So where does one discover what is available in difficult airway tools? My two favorite sources are Cook Medical and Portex. Cook Medical is an American company established in Indiana in the latter part of the last century, and Portex is a British company, now part of Smith's Medical, and each website has a catalog. From the Cook Medical line, we have an Aintree catheter, which has a 19 French outside diameter and a 4.7 millimeter internal diameter. It is an airway exchange catheter. A typical fiber optic bronchoscope has an outside diameter of 4.2 millimeters. Therefore, a bronchoscope can be inserted into an Aintree because the internal diameter of the Aintree is smaller than the outside diameter of the fiber optic bronchoscope. I suggest you read the instructions for all devices before you use them. Also from the Cook Airway catalog is the Frova. It is an endotracheal tube introducer. It comes in two sizes, 8 French and 14 French. The 8 French is approximately 3 millimeters in diameter, and the 14 French is approximately 5 millimeters in diameter. It is available with and without a stiffening stylet, and as mentioned on previous slides, and as you can see from the photograph, it has a coude tip, and it allows you to lift up the epiglottis and improve your Carmack-Lehane view. Like all airway equipment, I recommend that you read the instructions for use before you actually use it. With respect to airway adjuncts, this slide shows a photograph of an intubation pillow where the final position is that of sniffing the morning air with cervical flexion and a small degree of atlanto-occipital extension, which may be further exaggerated during intubation, resulting in a true sniffing position and alignment of the laryngeal and pharyngeal axes. This table from a Portex brochure or catalog provides information regarding the suggested tracheal tube internal diameter and external diameter for neonates, pediatric, and adult patients, and average length of tubes when inserted orally or through the nose. Also note there are recommended suction catheter sizes for tubes. Some anesthesiologists believe that straight blades are better for intubating children. Dr. Gerald Lerman at the State University of New York at Buffalo and his investigators attempted to answer this question. Published in 2014, this study compared laryngoscopic views with a size 1 Miller blade and a size 1 McIntosh blade in infants and children under the age of 2. The investigators concluded that the laryngoscopic view was similar when comparing the Mac and Miller blades. It was their opinion that the Mac size 1 blade yielded a superior laryngeal view if it is used to lift the base of the tongue rather than the epiglottis. Around the same time, other investigators were also trying to answer the same question. This study was performed in 120 children in the years 2010 to 2011 and was of a crossover design. Each patient underwent laryngoscopy with each blade. Younger children were intubated with the size 1 blade, and older children with the size 2 blade, but all children were under 2 years of age. The authors conclude that each blade provides similar laryngoscopic views and recommend that practitioners be familiar with both blades. The publication did indeed provide some interesting post-publication reading with letters commenting on the study and providing historical information about the McIntosh blade, and as previously detailed in this video cast, Dr. J.J. Henderson and his straight blade came up. And this slide summarizes a reader's viewpoint that whatever laryngoscope is used, the principles of laryngoscopy remain the same. If these, namely correct head position and adequate anesthesia, are ignored, no laryngoscope will give success. The secret of successful intubation lies within anesthetist, not with any particular laryngoscope. The authors replied to one part of the comment in responding that the size 1 Macintosh blade was indeed a pediatric version of the adult blade, and it was true that Dr. Macintosh himself disliked it. However, they pointed out that they are commonly used laryngoscope blades. The authors further comment that textbooks describe several approaches to exposing the glottis in infants with a Miller blade, just as I brought to your attention earlier in this video cast. And finally, the authors, in a reply to comments on their paper, raise the publication by Dr. Eschmann and reiterate the findings of the group from Buffalo, New York. While the debate of straight blade versus curved blade may have been raging for a number of decades, the advent of video laryngoscopes raises another comparison. This is a recent study from France. Comparison of the McGrath-Mack video laryngoscope with direct Macintosh laryngoscopy for novice laryngoscopists in children without difficult intubation, a randomized controlled trial. This is one of the results in the publication, and I'll just bring to your attention that the time to intubation in the direct laryngoscopy group was 42 seconds with a range of 35 to 50, and in the McGrath group 48 seconds with a range of 43 to 58 seconds, which is a rather long time for intubation, but you must remember that these were novice laryngoscopists. In conclusion, the authors say that the McGrath-Mack cannot be advised as a first choice device for performing intubation in children who do not have difficult intubation criteria. It does not shorten the time to intubation. However, they do believe that it may play a role in training in daily practice in order to teach how to use the device, and perhaps more studies as a teaching device are warranted. This is one of the studies that I remember which compare straight blades to curved blades, and as you look at the list of names of blades, they start becoming completely unrecognizable. At least the McCoy, Bellscope, and Lee FiberView blades are not ones that I've ever seen or used. Yet nonetheless, the authors conclude in the end that a curved blade is best used to improve intubating conditions. The next 7 slides are excerpted from the textbook on otolaryngology by Cummings. This table comes from the most recent edition of Cummings' textbook on otolaryngology, and starts with the most basic difficult airway intubation tools, the face mask, commonly used by anesthesiology and not at all used by otolaryngology head and neck surgeons, and progresses through video-assisted laryngoscopy, which both specialists may use, supraglottic devices, which are typically used by anesthesiologists, the blind nasal technique by anesthesiologists, the digital technique by anesthesiologists, and the lighted stylette, also by anesthesiologists. Progressing to more exotic techniques, conventional laryngoscopy is typically used by anesthesiologists, but endotracheal tube guides may be used by either specialist. Rigid laryngoscopy using the Hollinger laryngoscope or the dado laryngoscope are typically used by otolaryngologists. And from the textbook I can tell you that it is labeled as the laryngoscope commonly used for difficult airway intubation. Rigid bronchoscopy is generally the field of otolaryngologists or perhaps interventional pulmonologists. Fiber optic bronchoscopy is commonly used by anesthesiologists, and the early precursors of difficult airway equipment, the Bullard, the Upshur, the Wu laryngoscopes, are obviously in the field of anesthesiology. Retrograde intubation is a technique which may be employed by either specialty. This slide is largely presenting more invasive techniques such as percutaneous cricothyroidotomy, which anesthesiologists may become skilled in. Tracheostomy is obviously something that a head and neck surgeon or otolaryngologist would be expert in. This is a photograph from Cummings' textbook showing the Hollinger laryngoscope, which is labeled as the most dependable scope for direct laryngoscopy in the management of the difficult airway. As you can see, cuffed or cuffless tubes may be passed through the scope, and the use of an Eschmann stylette is sometimes employed in order to guide the small endotracheal tube into the narrow airway. For what it's worth, this letter, published in Anesthesiology in 2004, provides some history of the Eschmann tracheal tube introducer and clearly explains why it is incorrect to call it the gum elastic bougie. What appears to be the case is that a gum elastic bougie was a urological tool used for dilation of urethral strictures and adapted for guiding endotracheal tubes into the airway. And again, for what it's worth, this letter did not change the common use of the phrase gum elastic bougie when describing endotracheal tube introducers. I strongly recommend that you read this chapter from Hagberg and Benjamoff. The laryngeal mask airway has a very interesting history and has evolved to have many uses. there are some specialized laryngeal mask airways designed for intubation. Although this index mentions its use in non-supine positions, I must confess that I've never used a laryngeal mask airway in a non-supine position. My summary of the LMA is that it was invented by Dr. Archie Brain beginning in the early 80s, I believe. It was released commercially in the United Kingdom in 1988 and probably in Canada at about the same time. It was approved by the FDA in 1991. Laryngeal mask airways were originally multiple-use devices, but now disposable devices are much more in use. And this slide lists a variety of LMAs which were invented by Dr. Brain. There is a website for that, and this is it. The LMA website by Teleflex has a wealth of information for you. I am not an expert in the LMA, but I have learned a lot about its proper use by reading instructions for use, and this is a reproduction of how to, starting with selecting the correct size, performing pre-use checks, and following the steps for proper insertion and maintenance of the device. One of the things that I have learned from reading the instructions for use is the detailed management of the cuff. As indicated on the instructions for use, the cuff should be deflated fully, then reinflated to 50% more than the maximum inflation value and examined for herniation or bulging, and the pilot cuff should be elliptical, not spherical. Not only are there detailed instructions for use in the pre-use phase, there are detailed instructions for use for clinical insertion. I am sure that all of us have seen a laryngeal mask airway inserted almost anyway and have it work. However, for what it's worth, the standard insertion method is outlined on this slide. It would seem to me that the easiest way to explain where the laryngeal mask airway is to end up is that the tip should be in the esophagus and that the laryngeal opening should be opposite the glottis without folding over the epiglottis. This paragraph, excerpted from Hagberg and Benyamov's textbook, addresses the learning curve. The authors express the opinion that correct LMA insertion may require much more than 10 to 15 insertions before competency is acquired. They also point out that anesthesiology residents often learn how to use an LMA in a teaching hospital where the caseload is weighted towards long and complex procedures. Dr. Brain has a suggestion on how to shorten the learning curve, and it's presented on the next slide. Dr. Brain proposed that an LMA could be inserted routinely at the start of a case and then switch to the preferred airway technique before surgery. His justification was that the skills acquired could be life-saving in the event of an airway emergency. If the LMA had been inserted successfully and the patient subsequently proves impossible to intubate, the clinician now has already proven a way of at least maintaining oxygenation. Alternatively, if the clinician has been unable to insert an LMA successfully, time is not wasted. And finally, on this last slide of the third video cast, I am providing you with the references which I used for the production of this video cast. I recommend each and every one of them for your more detailed study.